My name is Sarah Pack, and my geriatric syndrome presentation is on urinary incontinence. Introduction, background, and significance. The Urology Care Foundation defines urinary incontinence as leaking of urine that you can't control. According to the CDC, over half of non-institutionalized adults age 65 or older have incontinence issues. Based on the number of patients who suffer from incontinence, those of us in the nursing profession should be knowledgeable on the subject in order to improve prevention, early recognition, assessment, diagnosis, and treatment. Subjective data. The patient that I chose for this presentation has the initials LE. She's a 71-year-old female with no known drug allergies. Current medications include Caltrate 600 plus D3, cyanocobalamin, esomeprazole, fluoxetine, hydroxyzine, levothyroxine, meloxicam, metoprolol, and a one-a-day multivitamin. All patient immunizations are up to date, including the Prevnar 13, Pneumovax 23, Shingrix, and Fluarix. Health maintenance and disease prevention, a CBC, CMP, thyroid panel, lipid panel, and a hemoglobin A1C were last drawn in September of this year, shortly before her annual physical. They will be due again in September of 2019. A bone density scan is due in June of 2020. A colonoscopy is due in April of 2020. And her last mammogram was in 2014. Unless otherwise indicated, that will be her last mammogram because they are not recommended for women age 75 or older. Past medical history. Comorbid conditions include anxiety, a B12 deficiency, depression, GERD, hypertension, hypothyroidism, and rheumatoid arthritis. Her only hospitalizations were for childbirth in 1967 and 1969, and for an open cholecystectomy in 1989. Living conditions are that she is widowed and lives alone. Typical presentation. Depending on the type of incontinence, there may be complaints of involuntary urine leakage on effort, exertion, sneezing, or coughing, or accompanied by or immediately preceded by urgency or urinary frequency. Common complaints include vaginal irritation due to urine leakage and the hesitation to participate in activities outside the home due to fear of loss of urinary control. Review of systems and pertinent negatives. Genitourinary. Patient denies any decreased force of stream, dribbling, dysuria, hematuria, hesitancy, nocturia, polyuria, or abdominal pelvic pain. She has complaints of loss of bladder control when coughing, sneezing, laughing, or lifting heavy objects, and this has been going on for the past 2 months. Objective data. All vital signs were within normal limits. Her blood pressure was 122/84, indicating good control of her hypertension. There were no positive physical assessment findings. The abdominal exam was negative for surgical scars, hernias, masses, organomegaly, and distended bladder after voiding. There was no tenderness of the flank and costovertebral angles upon palpation, and she was negative for pelvic organ prolapse. Screening tools. We utilized 4 different screening tools on this particular patient. The first one we used was the Geriatric Health Questionnaire. It indicates a loss of bladder control based on her answers. The next one was the Lawton-Brody Instrumental Activities of Daily Living Scale. On that she scored an 8, which indicates that the patient is independent with all ADLs. The third was the Urogenital Distress Inventory Short Form, which she scored a 4 on. That indicates that the patient is experiencing moderate distress over urinary incontinence. And the fourth and final screening tool we used was the Incontinence Impact Questionnaire Short Form. She scored a 1, which indicates that urinary incontinence slightly impacts the patient's activities, relationships, and feelings. Now on to the workup. For the diagnostics, tests such as the cotton swab test, cough stress test, post-void residual urine volume test, cystoscopy, and urodynamic studies are generally not performed or ordered by primary care providers. Patients are usually referred to a specialist for further workup. Labs that were ordered today include urinalysis and urine culture, which were both negative, and we also ordered a BMP, which was within normal limits. The treatment plan for this patient includes keeping a voiding diary, performing daily Kegel exercises, caffeine reduction, and fluid management. The American Urological Association recommends the use of alpha agonists such as pseudoephedrine as a first-line option for the treatment of incontinence. However, in the case of this patient, medication was not utilized pending evaluation by a specialist. A referral was made to the Novant Health Pelvic Health Center for further workup and treatment. Differential diagnoses include urinary tract infection, which was ruled out because the urinalysis and urine culture were both negative, a urogenital fistula, which was ruled out because the patient was negative for continuous urine loss and no associated symptoms, and finally atrophic urethritis. The patient was negative for urinary frequency and dysuria, ruling out that diagnosis. The final diagnosis for this patient is stress incontinence, which was based on all subjective data. The patient complained of loss of bladder control when coughing, sneezing, laughing, or lifting heavy objects, which is the typical presentation of this type of incontinence. When considering the challenges and barriers to the treatment plan, the only challenge to this plan is that with it being a very conservative approach to treatment, in order for it to be successful, the patient must be compliant with pelvic floor exercises and lifestyle modifications. My preceptor and I determined that no community resources were necessary for this patient. However, after being referred to a specialist, multidisciplinary health team members will potentially be involved, including a urologist or urogynecologist, a physical therapist, and a pharmacist. Now for the discussion. A modifiable health behavior that was identified for this patient was her caffeine intake. She had no identified social determinants of health. However, when discussing the socioeconomics of urinary incontinence, women who fall at or below the poverty level and minorities may have limited access to health care or may not have the financial means to pay for testing or treatment. Fortunately for our patient, that is not the case. Culturally speaking, incontinence leads to religious restriction for some Jewish and Muslim women related to the need to be clean for prayer. Muslim women also prefer female providers, which may not be an option in some areas. Less than 50% of Jewish and Muslim women seek care for incontinence. In our patient's case, she's Christian and reports that she has no socioeconomical barriers. And there were no identified legal or ethical issues for this diagnosis or this patient. In conclusion, while researching this topic, I received more education on the different types of incontinence, which was helpful in diagnosing this patient. I learned about the diagnostic tests that are available for use in determining the type of incontinence the patient has and the etiology of the problem. I was also surprised to find out that while it is used primarily as a decongestant, pseudoephedrine is used as a first-line treatment for stress urinary incontinence. Perhaps the most important thing I learned during this process was how profound the emotional impact is for women who have incontinence issues. As providers, we can support them through this by supplying answers, options, and resources that enable them to be active participants in the treatment of this condition so that they never feel that the situation is hopeless. I hope you have enjoyed this presentation, and I thank you for watching.